Good afternoon and welcome to our Oak Bend Medical Center Happy Hour podcast. My name is Donna and I am your host. I'm very excited to introduce our guest today as we speak about orthopedic issues. Dr. Michael Maier is a general orthopedic surgeon working in orthopedics and sports medicine and an associate professor of orthopedics with Baylor College of Medicine. Dr. Maier has serviced this community for almost 20 years and has been dedicated to delivering high quality, compassionate care. He has not only chosen this area for his career, he has chosen to raise his family here. And you can often see him at the school events and in local stores. When Dr. Maier is not working, he enjoys spending his time golfing with his family. So much so, he is referred to as the golf doctor. Thank you, Dr. Maier, and welcome. We're glad to have you.
Thank you, Donna, for having me. It's always a pleasure.
Well, before we get started on the orthopedic thing, I want to congratulate. I understand your son just won a big golf tournament.
Well, they start to run together. He's pretty good. He wins a lot of tournaments, but he had a really good summer, and he's got a lot of opportunity ahead of him if he stays focused. His name's Mitchell Maier, very, very good golfer. His sister Melanie is also pretty good. She's 15 and she competes on a national level as well. But that's exactly correct that I spend the majority of my time when I'm not treating orthopedic injuries and sports afflictions that people have on the course with my family and my kids. It's kind of my second love.
Oh, wonderful. And can they beat Daddy yet?
Oh, I haven't been able to touch them for several years.
Ah, okay. Well, let's talk about what exactly, you are a general orthopedic surgeon. What is the difference between general orthopedic surgeons and orthopedic surgeons?
Oh, really nothing. A general orthopedic surgeon just means that we take care of most bread and butter orthopedic conditions. And there's subspecialists that only do a certain type of orthopedics. So my training, I did my undergraduate at University of Notre Dame. I then went to medical school at the University of Texas Southwestern in Dallas. And then from there, I spent 5 years in general orthopedic training at Duke University. And part of your general orthopedic training over the course of 5 years, you spend time doing total joint replacements. You spend time doing sports medicine, which might include a lot of ACL injuries, meniscus injuries in the knee, as well as rotator cuff, shoulder injuries, shoulder sprains, shoulder dislocations, things like that are very, very common injuries that all sorts of people in all different ages have. We also, as part of our training, do pediatric orthopedics. We spend time on orthopedic oncology, diagnosing and treating orthopedic oncological tumors. We also spend time during our training in spine, both non-operative and operative treatment of the spine. From there, when people graduate, they can go on and do an extra year of a fellowship. And that may be in joint replacement, it may be in orthopedic oncology, it might be in spine. So as a general orthopedic surgeon, I operated on the hand, the elbow, the shoulder, the hip, the knee, the ankle. I do not really operate on the spine. I will treat spine conditions non-operatively. People have back pain. As such, I will see them, and 80% of back pain doesn't require surgery. So when you're talking about the back and the neck and injuries or diseases of that, first line treatment is going to be conservative. And as a general orthopedist, I will see that as well. I have a nurse practitioner that works with me, and she is a chiropractor, was a chiropractor as well at one point, and she sees a lot of our non-operative neck and back pain in our clinic when people come in with that. But the goal of a general orthopedic surgeon is really to take care of the entire patient's orthopedic needs. Now, the nice thing is as part of Baylor College of Medicine, I have orthopedic subspecialists. If there's something that is not really bread and butter or extremely common, then I have some of the best specialists in the world just down at the medical center that I can refer them to. But I would say that about my partner, Dr. Thomas Parr, and I can take care of 90% of things that come into the clinic out here, and we feel very confident in taking care of that well. That is kind of what a general orthopedic surgeon is. So I do orthopedic trauma, I do orthopedic joint replacements, hip and knee replacements. I do sports injuries, including rotator cuff pathology, ACLs, meniscus injuries, ankle fractures. I probably do more bread and butter fractures than anybody else in Fort Bend County because I take a lot of call. I take a lot of call at Oak Bend Hospital. I take a lot of call at St. Luke's Sugar Land Hospital. And when people break a bone, they end up in the ER, they need a surgery in Fort Bend County. There's a pretty good chance that I'm going to be the person that the ER doctor calls.
And we're very glad to have you. We love you at Oak Bend.
Always enjoyed being on staff at Oak Bend. I love the employees there. There's people there that have been there 25 years, and it's a great community to be a part of. So,
Dr. Maier, you talked about rotator cuff. And for some reason, I've been hearing a lot about shoulder pain and people talking about their shoulders hurting and stuff. How would I know if I had something wrong with my rotator cuff, or could it be just arthritis?
Well, I would say that, as a general orthopedist, one of the most common things that comes into my office is a referral from a primary care doctor, or a patient just calls and make an appointment that has shoulder pain. And oftentimes there's shoulder pain. It's associated with activity. There may be associated weakness as well, and that's what causes them to call either their primary care physician first, or if they can get in without a referral to see an orthopedic specialist, then they just make an appointment. And when you talk about shoulder pain and weakness, the most common thing I see is rotator cuff pathology. There was a study in the 70s that looked at cadavers and found that 80-year-old cadavers that were dissected out, 90% of people have rotator cuff tears. So rotator cuff pathology or rotator cuff tears are really part of normal aging. Now, there's different types of tears. You can have little partial tears where you look at the tendon, it may be degenerative, it may be wearing out over time, but it's not completely torn off the bone. So the rotator cuff is a set of 4 muscles that form a cuff around the humeral head, which is the ball of the shoulder. So the shoulder is a ball and socket joint, and the socket is very shallow. Compare that to the hip, you have a very deep socket. So in the hip joint, it's a ball and socket joint, but the socket is very deep, and therefore there's a lot of bony stability. In the shoulder, it's a very shallow socket, and therefore the stability is really, it depends on the capsule, which keeps the ball in the socket, but also the muscles. And the muscles, when they are functioning correctly, the 4 rotator cuff muscles keep the ball in the socket where it is supposed to be. When it tears and it's dysfunctional over time, the shoulder will start to come out of the socket, and people will develop a pattern of arthritis that we call rotator cuff arthropathy. Now, that arthritis is caused by the rotator cuff tearing, becoming dysfunctional, and then you develop rotator cuff arthropathy. Okay, now there's other types of arthritis that you can get in the shoulder. You can get some wear and tear of the cartilage in the bone where the rotator cuff is functioning pretty normally, and that's just called glenohumeral arthritis, or sometimes people generically will use the term shoulder arthritis. There's also a small joint in the shoulder where the clavicle comes in, and it attaches to the top of the scapula, which is a part called the acromion. So we call that the acromioclavicular joint, which is a little small joint that doesn't have very much motion. And you can get arthritis very frequently in that joint. I would say that if a 50-year-old comes into my office with shoulder pain and I take x-rays, probably about 50 to 75% of the time, they're going to have radiographic arthritis at that little small joint, the acromioclavicular joint. Fortunately, even though you can see some changes on x-ray that we call arthritis, it's not always symptomatic and it doesn't really hurt that often. So we don't have to do anything about it. You only treat the arthritis if it's symptomatic. If I x-rayed everybody's knees who were 50, everybody's shoulders that were 50, I would find a lot of radiographic arthritis, which when you're talking about osteoarthritis, you're talking about generalized wear and tear of the joint. And that happens normally in most people over the general normal aging process. And so you only treat what's symptomatic. And so when somebody starts to get pain and weakness in the shoulder, most of the time, if you're over 35 or 40, it's wear and tear of the rotator cuff. That's the most common thing that we see. So how much it's torn depends on what we do to treat it. If it's completely torn off the bone, then it's non-functional and it can't keep that shoulder in the socket. And if it's in a young person, it needs to be fixed, or that shoulder will come out of the socket. People will develop that pattern of arthropathy over a couple-year period, and the rotator cuff later on will not be fixable or functional. And so that can be a big problem in a younger person. If somebody's 75 years old and the rotator cuff tendon is just completely degenerated, it's worn out chronically over time, and it's torn oftentimes in that population, we can treat it with an injection, some strengthening of the other muscles. And part of the reason is a 75-year-old isn't having to do the things that a 45-year-old laborer would have to do with overhead activity and lifting as such. And so whenever you treat a condition, you have to look at the patient, what their age, what their health level is, what their physiologic age or activity is. And that means that you can have a 75-year-old that's very active and functionally they're a 55-year-old, and you can have vice versa, a 50-year-old who is rather sedentary, may have some comorbidities, and from a physiologic standpoint, they're more like a 70-year-old. And so you have to take a full history, do a full physical exam, find out what the patient does in their activities of daily living, because that will also determine how we treat an orthopedic affliction or pathology. It's different in every person. So oftentimes when somebody comes in, the first thing and one of the most important things I ask them is like, how do you spend your days? What do you do for a living? And the answer to that question will help me guide how to treat them. And you don't want to just fix a torn tendon that we see on an MRI or a torn meniscus that you see on an MRI. You have to look at how that affects the patient and whether or not you can do conservative measures or you need to be more invasive and consider surgical options.
Dr. Maier, when would somebody see the orthopedic? At what point? Because sometimes people go a little too long. Maybe they're going to the family practice and just getting medication. When is the time to see the orthopedic?
Well, I mean, I think most primary care physicians are a good resource to help you decide that. And I think that, the Oak Bend Medical Group has some excellent family practice providers. And there's some excellent family practice providers here in Sugar Land that can help their patient determine whether or not it's at a point to where, okay, some Aleve ibuprofen is not knocking out this inflammation. There may be something more significant, something that requires a secondary intervention, which may be a shot, it may be physical therapy that we do in the orthopedist office, and at times it may be surgery. So I would start with primary care physician, and if you've looked online and maybe you've tried some home exercises and it's just not getting better after about 2 weeks, then it's probably time to consider seeing a specialist about it. If you injure yourself and you think you tore a tendon or a muscle or sprained something, starting with some over-the-counter anti-inflammatory Tylenol, some rest, some ice, if you don't have any medical conditions such as blood pressure that would prohibit you from taking some over-the-counter medications, then I think that's a first start. And if it doesn't improve significantly over, 7 to 10 days, then you need to probably seek medical attention.
So if I'd have to have rotator cuff repair, is that a stay in the hospital or is that an outpatient procedure?
When I first started practice, maybe 15, 20 years ago, people were doing these overnight. I think in my training at Duke, people would stay overnight at a surgery center and go home the next day. At that time, we were doing part arthroscopic repair, part arthroscopic surgery, but we were fixing the tendon through a small open incision. In the past 15 years, the majority of orthopedic surgeons and who fix rotator cuff, which is all general orthopedic surgeons and a lot of orthopedic surgeons who call themselves sports medicine specialists, we pretty much all fix these arthroscopically now. The surgery can take anywhere from an hour and a half to 2.5 hours, depending on how extensive the tear is. Sometimes you go in and you look and you don't have to fix a tendon. The surgery can be very short. If you fix a tendon, that's going to have a more extensive post-operative protocol and recovery. But in this day and age, almost all rotator cuff surgery is being done as a strictly outpatient procedure where the patient comes in, has the procedure, and goes home the same day. You'll pretty much go home with a sling. And if there is a repair, which means that we have to put what are called suture anchors into the bone where the tendon detached from, and the anchor, which is a little screw, has sutures on it. That suture gets passed through the torn tendon, and then you tie down the tendon to the bone. Well, when you're tying that tendon down to the bone, it takes about 6 weeks for biologic healing to occur, which means that you have to protect the repair. The little anchors that we use are not strong enough by themselves to hold the torque and forces required for you to go back to doing lifting, unrestricted activity immediately after surgery. So we restrict the patient for about 4 to 6 weeks to allow biologic healing. Now we can start some gentle range of motion exercises to prevent the joint from getting stiff. The joint will always get stiff, but we want it to get a little less stiff, and then that will make your recovery from 6 weeks to about 4 to 5 months a little bit quicker, where you're regaining that strength and you're getting that motion back. And that's pretty much the recovery that you do post-operatively with a physical therapist and home exercise program that's guided by the therapist and your orthopedic surgeon, is that you're gaining strength and you're gaining mobility of the joint. Because if you did what you're supposed to by protecting the repair, your shoulder will be weak and it will be stiff. And so you have to gain that from about 6 weeks on. I don't know if that answered the question or not.
You did answer the question. It sounds like a painful recovery, but something that's necessary.
Yeah, sometimes though, if you have a big tear, I mean, it hurts a lot. It causes night pain. You can't lift your arm up. And, people are in a lot of discomfort from the tear. And it's not uncommon that about 2 weeks after the surgery, you come in and the pain at rest is improved. And then over the course of your rehab, you'll have a different type of pain. You'll get pain from the stiffness, which is what we call frozen shoulder, or another word for that is adhesive capsulitis. And in the setting of a shoulder surgery, we refer to it as secondary adhesive capsulitis because we created that adhesive capsulitis or frozen shoulder. In Latin, adhesive capsulitis means, sticky capsule, but that's normal to get that after surgery.
Well, we talked about adults and we touched on kids, But with school starting and they've been out of school and probably a little more sedentary than usual, now we have all the athletics and everything coming up. Softball, baseball, football, all those can create shoulder pain. How much shoulder pain in a child is normal? And when should they seek help with that?
I mean, again, I think if there's a significant traumatic event and there's a lot of pain and the child cannot use the shoulder or any joint or cannot bear weight on a lower extremity joint, then you need to probably take them into an urgent care if it's on the weekend, or get an appointment to see an orthopedist during the week so you can get an x-ray and make sure that there is no fracture. Children, the weak link is the growth plate. And so fractures occur around the growth plate commonly. The tendon is usually, and the ligaments are very strong. They're actually stronger than the growth plate. And so you don't see rotator cuff tears in young kids that are skeletally immature. You'll see a growth plate fracture. Now, growth plate fractures can occur from a fall, playing football, an acute fracture. They can also be overuse injuries. So one of the more common things we'll see in adolescent athletes is they will come in with what we call little leaguer shoulder. And it's an overuse injury where the repetitive sports activity is creating a stress fracture or microfractures at the growth plate. And that can cause some problems if you continue to aggravate it. So really the treatment in that case is going to be rest and refraining from the activity. Now we call it little leaguer shoulder because the classic activity is going to be throwing a baseball year round. And usually I see this in kids who play select baseball and they play year round, and it's almost always the pitcher or the shortstop that is really good, one of the better players on the team, and the parent comes in with their child, and oftentimes the parent is the coach. And it's one of the worst things I have to do as a surgeon is to tell the patient and the family members that their son has to rest and stop playing baseball for 2 or 3 months, and that to provide them reassurance that if they're really this good at baseball and this is something they want to do down the road later in high school and in college, then actually it will benefit them in the long term to rest the arm now, focus on core strengthening to where you're throwing and you're getting your velocity from strength in the legs, the core. Those muscles are very important to take the stress off of the shoulder or the elbow in the throwing athlete. And so part of the treatment the mainstay will be rest, but also getting them in with a good physical trainer that can work on core strengthening, lower extremity strengthening in these overhead athletes to get them, when they go back into the sport, to prevent injury from reoccurring, because it will reoccur if you just go back to doing the same thing year round and throwing. You don't always see this just in pitchers too. You can see it in volleyball players that play year-round volleyball, overhead activities. You can also see overuse injuries in swimmers. Occasionally, I don't see it as much in football players, quarterbacks, things like that, but certainly you could have that happen as well. And then in the same thing in the lower extremities, you get overuse issues in runners and soccer players that are doing a repetitive activity, and oftentimes they're not focusing on their core. They're not focusing on their abdomen, their upper back, their torso, and all the pressure and forces of that activity are going to the one joint. And so it's really important to cross train and not just do that one athletic activity. I've seen with my kids who play on golf teams, I've seen kids who hit a lot of golf balls over and over and over, and they don't focus on their core strength. They'll get injuries in their wrists, they'll get stress fractures of their spine, and that's just from the repetitive twisting action. And so the way to prevent that is to focus on core muscle strengthening and stretching type exercises.
And there are trainers out there that work with kids of that age.
Absolutely. There's a whole slew of good places.
So what made you get into orthopedics, Dr. Maier? Because this is obviously something you love.
Well, I was an athlete as a child, and I was never a good patient. I'm still probably not a good patient, but I remember breaking an ankle in high school, and I actually remember cutting my own cast off to go play in a baseball state championship. And now I am paying the price with arthritis of my ankles in my late 40s. And I played basketball at a high level to my mid 30s and blew my own knee out while I was at Duke playing basketball in Cameron Indoor Stadium as an orthopedic resident. And so I think sports injuries and fractures have been kind of a part of my life. And I liked the biologies and sciences in high school and started at Notre Dame pre-med and just kind of followed that course.
Awesome. Is there one thing you would like our listeners to know out of all the things you can do? Is there one piece of advice you want to give them?
Best advice to stay away from me is to exercise regularly 3 times a week, low impact exercise, swimming, elliptical exercise, bike, different things, as well as weight loss. Weight loss is something that I talk to my patients every single day. Probably half the patients that I see are for the knee or the hips or the ankles wearing out. Most commonly, it's the knee, it's the medial meniscus at the knee. And if you can keep your muscles around your joints strong and healthy, they will unload the joints. If you can keep your core strong, it will keep you from getting overuse injuries. And it's pretty simple that the less weight you carry, you're going to put less force on your spine, your hips, your knees, your ankles. You're going to prevent them from wearing out at an early age. And that's going to lead you into the orthopedic surgeon, which you're not even thinking about right now if you're anything like I was when I was in my 20s and 30s. And it's going to affect your job. It's going to affect your ability to do the things that you like to do, because if you have to have surgery, you're going to miss work, you're going to miss time, and it's going to cause you pain. So the best way is to not come and see me. And that's with low impact exercise and weight loss. Those are the 2 most important things.
We will give you Dr. Maier's information on this podcast if you'd like to call and make an appointment with him. He is a fantastic physician, wonderful person, and a great person in the community. So I want to thank you, Dr. Maier, for joining us today, and a big thank you to our listeners for tuning in. Beginning now, set an intention and a relentless focus on living your life as the greatest person you can be in all situations. Please join us next week.
Thank you for joining us today on Oak Bend Medical Center Happy Hour podcast. We hope you enjoyed today's broadcast and invite you to email us at oakbendhappyhourpodcast@obmc.org with any questions or topics that you would like for us to cover. Remember, you can find us here each Friday at 5. Until next week, be mindful and stay healthy.